Hello, welcome to the part 8 and the final part of my series of talks on introduction to dermoscopy for GPs and GP trainees. My name is Dr. Chris Yapia. I'm GP with extended role in dermatology. So this final part, we are going to look at a few benign lesions, and then we end with some nail dermoscopy and some key points, kind of advices and gems that will help you in your clinical management of lesions. So a few benign lesions first that we can go through, very common ones. Dermatofibromas. So these are very, very common in general practice, also known as histiocytomas. So clinically, dermatofibromas are firm, fibrous consistency, and they surface dimples on compression. Dermoscopy of dermatofibroma usually shows a faint network or a pseudo network surrounding what looks like a pale amorphous area. So a very pale amorphous area sometimes might be pigmented, and sometimes a central white area with white lines and brown holes. So this pale amorphous area might look different on pigmented skin. So in Black and ethnic minority skin, the central area might actually be a little bit more darker rather than pale, and still all features of dermatofibromas. So this is what you look for in dermatofibroma. You have this pale amorphous center surrounded by this pinkish area of a pseudo network, which is not really like a true network. And obviously, clinically, the lesion will be felt palpable, dimples. That tells you you're dealing with a dermatofibroma. Another one is a pale amorphous area in the center with kind of a pinkish area of a pseudo network, not a true network. Hard lesion on clinical examination, palpable nodule, dimples, clinical correlation to dermoscopy help you confirm dermatofibroma. Sebaceous hyperplasia is another commonly usually referred lesion to secondary care, which are multiple small clinical lesions on the surface, on the usually face mainly, and most of them are less than a centimeter, and there will be multiple of them. And the reason why they are sometimes referred for suspected look like BCCs because of the vessels that you see there, which typically it looks like a crown vessel, so surrounding vessels with some creamish surrounding area in the middle. So you have this pale yellow lobules or creamish lobules in the middle around the central follicular open. That's where the central follicular open will be, and because of that, people will look like it looks like a crater. Is it a BCC? Because that idea is there, but it's not ulceration in this at all. And really, if you look in dermoscopy, you see a bit of telangiectasia. Tends to be uniform, crown-like vessels on the edges, and this is kind of a sebaceous hyperplasia. This is the creamish area or whitish area in the middle. And also, again, this typical lesion shows that whitish area in the middle. You can see the vessels there. Yes, I can see why people will refer this to as arborizing blood vessels, but it's really these whitish areas in the middle that makes you tell you clinically this is a sebaceous hyperplasia. Also, there'll be multiples of this, and you rarely will you find a single sebaceous hyperplasia. Maybe some mostly patient may be immunocompromised or immunosuppressed on some chemotherapy treatment, will present with these kind of lesions. But this is sebaceous hyperplasia. Nail dermoscopy finally is a thing I want us to look at. Again, the dermoscopy, apart from its uses in pigmented, non-pigmented lesions, has some role in helping in making diagnosis in the nails. It helps recognize pigmented changes and what is a melanechia, and then the nail plate, as the nail plate is semi-transparent and keratinous structure. So usually nail is normally not pigmented, but it appears discolored because of pigment on top of the nail plate, within the nail plate, or on top of the nail bed. Okay, and also the pigments may arise from the distal or proximal nail matrix. Now, longitudinal melanechia is due to activation of melanocytes in the nail matrix. It is more common in darker skin individuals. So dark skin individuals, you see longitudinal melanechia, and it also may be affected by other several nails rather than a single nail. The band may occasionally extend across the entire nail, but transverse melanechia is rare. So anything transversely, it's unlikely to be a melanechia. Longitudinally is a melanechia. Okay. Now, exogenous pigments, tan, silver, tar stain, henna, and other things. Also, you can look at it on dermoscopy to see, could be something exogenous pigment, showing you that obviously ethnic pigmentation, skin type 4, 5, 6 usually will have a dark longitudinal ridge, which is shows you that there's a variation in nail bed. Inflammatory skin diseases can demonstrate with some sort of nail changes. In psoriasis, you see pitting, lichen planus, you can see onycholysis, and things like that on the nail. And obviously, the key is this multiple or is it solitary? So if it's multiple, then you're thinking of inflammatory skin condition of the nail. Trauma, friction, biting, radiotherapy, infections, obviously paronychia, onychomycosis. Particular infections is Pseudomonas. So I saw a patient some time ago in two-week clinic who had this green pigments tinge on underneath the nail bed, and it has been referred to suspected melanoma. Obviously, the patient, on history, you realize that he's a keen gardener, and therefore he's been digging and rarely uses any gloves, and he's going to develop some Pseudomonas, which has this greenish appearance in the nail. If you're interested in the treatment of Pseudomonas, nail infection is you ask the patient to soak it in vinegar daily, and then you apply ciprofloxacin eye drops. Yeah, the eye drops on the nail bed, and you do it several several weeks, and sometimes even a couple of weeks, and you can see it slowly helps clear it up. Which obviously you can go oral cipro, but I think the eye drops is quite safer. Causes of longitudinal melanechia: drug reactions, hydroxyurea, antiretrovirals, antimalarials. Think about endocrine disease, Addison disease, also non-melanocytic tumors. So SCCs can present on nails in situ. So it's quite complex where it looks like as well. So SCCs, onychomatricoma, myxoid cyst. So digital myxoid cyst, where you can see either a lump on the nail bed or at the beginning of the nail bed, and then there is either any indentation in the nail bed, and most patients, they might have a history of ganglions or arthritis, and the digital myxoid cyst can bring a deformities in there. So viral warts or other things, and then melanocytic nevus of the nail bed. So this is also melanocytic nevus, benign melanocytic nevus. You can get lentigo, benign melanocytic hyperplasia, and as well as what you don't want to miss is a melanoma, malignant melanoma of the nail. So a couple of photos of the nail changes. This is exogenous pigmentation, really nicotine stain. This is or deaths or something there. This is trauma. There you can see the transverse lines. There's just a little bit of blood there, and it's trauma. And also there is here there is here Pseudomonas infection here, and also there is also dermatophyte infection here, as well as this is what I told you about Pseudomonas infection. it looks greenish in appearance, and also there is a bit of a fungal nail infection here. In these are all things that you can see on dermoscopy. So mainly dermoscopy nail is in the nail is used to assess pigmented streaks or bands which usually extend from the proximal nail fold adjacent to the cuticle to the distal edge. Blood spots is important to assess that in dermoscopy. Subungual hemorrhage, very, very common from trauma, or whether the patient had notices or not. Similar to the talon Y in my previous uh, videos. In this, usually on the nail bed of the toes, the patient will tell you that they often don't remember any trauma, and then there's a blood spots there. If you do use dermoscopy, look at it, you can see that this looks like dry altered blood. Admittedly, it takes a long time to clear on its own. I've seen some that takes months, but the dermoscopic pictures can reassure you that it's subungual hemorrhage rather than a melanoma. And obviously light to dark brown colors of bands to see. You can see regular thin lines, which is melanocytic hyperplasia. You can see irregular lines that you worry about melanomas in dermoscopy. When you see gray background, it tells you there might be some epithelial melanin. And then you can see micro Hutchinson signs where you can see cuticular pigmentation, which is not easy to see with a naked eye examination. So this is very, very important, because if you see Hutchinson signs, that's an early signs of melanoma, and dermoscopy can help you to demonstrate that on Hutchinson sign. You can see some microscopic groups as well on dermoscopy, and then either granular inclusions or tiny gray brown dots indicative of melanocytic origin. So there is a lot of things that you can see on dermoscopy. So this is a benign mole. You can see that this nail bed matrix the nail bed is not involved, so there is no Hutchinson sign. This is a melanocytic nevus on the nail. This is a lentigo, which is much a bit lighter brown pigmentation, and you can still see lentigo on the nail. Important to distinguish is subungual hemorrhage, and subungual hemorrhage will always look like this, or sometimes very difficult, subtle at the corners, and they're quite sharp, demarcated, black, red, purple, bluish, or like all the features of blood, altered blood there. With time, you can see that it starts fading from the distal edge. If you see a melanocytic lesion, it usually goes throughout. By subungual hemorrhage, it might be localized at the corner of the nail bed, and dermoscopy tells you that this is blood rather than melanoma. Melanomas in the nail should be considered if the pigmentation affects a single nail, especially if it's of recent origin in adults, and a thumbnail and great toenails are most often affected. So when melanoma may affect the nail bed or subungual area or the matrix, you can get a pigment within the nail plates. In nail matrix melanoma, there you see these longitudinal brown lines with irregular coloration, spacing, or thick disruption of the parallelism within the nail, brown background, and also when you look at the cuticle, some Hutchinson signs as well. So nail plate fissures or destruction can be seen in as part of melanoma in the nail. So this is a Hutchinson signs. You can see the cuticle, you can see the pigmentation there. You can see the pigmentation there. Really, really difficult. You can see the parallel bands there. This is clinical, and this is dermoscopy. And parallel bands, you can see uneven colors. So the two different colors or three different colors. It's a bit pale, it's a bit darker, and this is darker here. And you can see the cuticle involvement on dermoscopy. This is a Hutchinson sign of a melanoma. Again, obviously, in very advanced stages of melanoma, it can be quite horrible. You can see a destruction, the whole obliteration, and nail melanoma, and this is quite a nasty melanoma late presentation. Okay. So to conclude, my series key points to remember is that the evaluation of all lesions in patients with multiple NEVA is important, since it allows the recognition of the predominant neval pattern and subsequent identification of lesion within a deviant pattern. So it's really important that you look at all the moles of a patient when they present to you something which looks different. So the ugly sign, ugly duckling sign. The predominant nevus pattern is influenced by the patient's age and also the skin type. Okay, as I say, skin type, the darker your pigmentation, you tend to get more of a darker tinge in the middle of the mole, and a kind of a pale network are the peripheries in melanocytic nevus, benign melanocytic nevus. Growing nevi are common in young adults. Okay, the growing lesions are suspicious for melanoma when seen after the 6th decade of life. If you see any growing lesion, worry about melanoma. Over 60s. Growing lesions showing contemporary signs of regression, which is scarring, fibrous changes, 2-week wait, irrespective of the patient's age. Again, facial nevi in adults are normally nodular, so either the Meshins type. When you see a flat facial lesion in an adult which shows a network, be suspicious of a melanoma. If you do dermoscopy and it shows it does not clearly define a solar lentigo or the features of a lentigo, solar lentigo, then you are worried about either lentigo maligna or lentigo maligna melanoma. Single lesions at a chronically sun exposed area should always raise a suspicion of a possible melanoma. And then a large ill-defined melanocytic lesion showing a network is unusual after the age of 60. So you should worry about a lentiginous melanoma. Okay. If you see thick, fast-growing melanomas, may mimic blue nevus when it's quite deep. So any blue lesion lacking any convincing history, this is a key. Blue nevus we know are benign, but if there's no convincing history, they've not seen this before, it might be a thick, fast-growing melanoma, which has been unchanged, must always be referred to 2-week wait. And thick, fast-growing melanomas may be devoid of any discernible structures. Therefore, if the lesion lacks any specific pattern, which you use either pattern analysis, global features, or even local features, and it's not very falling into globules, network, you need to refer to 2-week wait. Yeah. Nodular or blue lesions with equivocal diagnosis. Okay, so you think a nodular lesion, you're not sure, equivocal diagnosis, blue lesions, it could be a blue nevus. You don't say, I'll follow you up, come back in 6 weeks, come back 3 months. Please refer to 2-week wait. Lesions with extensive regression features should always be referred on a 2-week wait. And then again, a lesion with a starburst pattern, which is invariably a Spitz nevus, must be referred 2-week wait when occurring around and after puberty. My personal rule is this: if in doubt, ask yourself, have I seen something like this before? Do I know if a benign tumor could look like this? Any benign tumor, can any of them look like this from my armory of knowledge? Or would I want to leave the skin tumor on my own skin and live with it? You want somebody to follow you up? You might not say, I'm curious what it is. Then refer to dermatology or GPSI. Thank you very much. And thank you for your patience and be able to go through all these 8-part series of introduction to dermoscopy. This is an evaluation form. It would be helpful to get some feedback for you. Below each video is also a link to this evaluation form that you can give me some feedback and what we can improve in the future. Thank you for listening, and speak to you soon.